sort of
as she'll start because Rajesh is not around, no, today?
Rajesh is not there.
हाँ, तर मी सांगते तिला फोन करून. I'll ask her if she's not.
She's representing IAP right now.
Yeah. एकच मिनिट सकत. Piyush, are you there? DigiShield मधनं कोण आहे इकडे?
Piyush आहे.
आहे ना Piyush? Sarita has actually joined, but we cannot see her and she's not audible, neither is she seen nor audible. तर ती परत जॉईन करतेय लीव करून. जस्ट फिगर आउट काय झालंय.
ती ह्याच्यामधनं झालेली नसेल ना ती पॅनलिस्ट
वर्मा का?
Sarita Verma, correct.
She's joined from the normal link.
I'll just promote her. Sir, just hold on. I'll promote her.
हाँ, correct.
She should have been in this only. मी मगाशी बघितलं अगदी सुरुवातीला. She's from there. She's seen here.
Good afternoon, everyone. Actually, I had joined due to some technical issues. I was not able to get through you all.
Okay. No, you had got the wrong link. That's why you couldn't join.
So, Dr. Suparna, am I audible?
Yes,
yes, ma'am. Yes, ma'am.
Sarita, could you just start off so that you know?
Sarita, you have to start the ball rolling because Rajesh is not there today.
Dr. Suparna, can you hear me?
Yes,
yes, ma'am. I can hear you.
We all can hear you.
Yes, ma'am.
You have to start the session from your side, Sarita.
काहीतरी टेक्निकल इश्यू येतो तिला बहुतेक.
नाही तिला ऐकू येत नाहीये बहुधा आपण बोललेलं.
हा बहुतेक काही कळत.
Are you able to hear us, Sarita? Are you able to hear us? Hello.
Dr. Parag, are you here?
Parag is not there.
कारण तो दिसतोय ना इथे म्हणून.
हा यस मॅम मी सरिताला फोन करतो एकच मिनिट.
नाही ऐक ना पराग, जस्ट इन केस देयर इज अ टेक्निकल ग्लिच ना, व्हाय डोंट यू जस्ट स्टार्ट सो दॅट आपण केस सुरू करू.
तुझ्याकडून चालू कर पराग.
तुझ्याकडून चालू करा ना पराग.
If the IAP president is there, then nobody else is required. I was not able to see you. त्यामुळे मी सरिताला बोलत होतो.
नाही पराग, if you could just start.
आता दिसतं.
हो.
Yeah.
Parag, start your video also.
So, welcome on behalf of IAP Pune. The series of case presentation by PG student. We are having the new case today. Dr. Suparna Gadgil, DNB resident from Dinanath Mangeshkar Hospital, will be speaker for this IAP case presentation for PG students, and mentor is Dr. Deshpande sir from Dinanath Hospital. So I request Dr. Suparna Gadgil to start the case.
Yes, sir. Good afternoon, everyone. This is a case of a 9-year-old female child, firstborn of a non-consanguineous marriage, Hindu by religion, resident of Chakan, informant being mother, was brought with chief complaints of joint pain and swelling for last 15 days, fever 1.5 months back. So the patient was apparently all right 1.5 months back when she started with about 8 days. It was gradually onset progressive. It was associated with generalized weakness. She started having fever on 5th to 6th day of illness, which was initially low grade and intermittent, about 2 to 3 spikes per day of around 100 to 101 as recorded by parents, without chills or rigors, and relieved temporarily by medications. She was taken to private practitioner for the same and was initially treated with some oral medications and was later admitted on 28th of February in view of non-relief of fever and body aches. During her hospital stay, some blood investigations were performed. Her parents were informed that the child had dengue fever and low blood cell counts, and she received some oral and IV medications. The complaints were relieved and she was discharged on 7th of March. The child remained asymptomatic for next 15 days. And after that, she started with joint pain 10 days back. Initially, the joint pain started with wrist joints, and then it gradually progressed to involve other large joints of both upper and lower limbs, ankle, knees, and elbows. It was additive pattern of joint involvement. The joints are swollen, red, painful to touch. Hello?
Yes, sir. Hello, sir. I'm trying to, log out and log in again. Maybe that might help. Yes, sir. Yes. We will continue, Parag sir has said. I will try to re-log in again or maybe change from laptop to the handset. Yes, sir.
Suparna, you can continue.
The joints are swollen, red, painful to touch, and the range of motion is limited because of pain. There is history of fever for last 5 days, which is mild to moderate degree without chills and rigors. It is continuous type of fever, temporarily relieved by medications. The patient requires antipyretic every 4 to 6 hours. The child was taken to her pediatrician for these complaints. She was investigated, and it was found to have some abnormality in her blood report. So she was referred to higher center for further management. There is history of 2 episodes of nose bleeding, which was spontaneous in onset, self-resolving, and it was scanty nosebleed. There is history of weight loss of about 3 kg in last 15 days. Facial puffiness was noticed by mother 2 days back, which is progressive. There is no diurnal variation in facial puffiness.
Suparna, can you just go to your first slide? If you could just go to your first slide of chief complaints there. It will be better. It's a small correction. If you written fever of 1.5 months duration, or it was 1.5 months back, that clarification needs to be given, which you further have clarified in your ODP. But please write your chief complaints in chronological order.
Yes, ma'am.
So if you have history of fever 1.5 months back, that should be on the topmost priority, followed by joint pain and swelling for 15 days. Okay.
Yes,
second thing, from this history, it is not being clear whether it is recurring fever or this fever has persisted for 1.5 months. Okay. So that clarity should be given in your chief complaints. Coming to your next slide of joint involvement. If you could go to that slide of joint involvement.
Yes,
can you go to the next slide? There's this joint pain. So you've given the type of joints. You've said that they are very large joints, which have multiple joints involved, which have gradually involved the large joints, both upper and lower extremities. Now, was it one after the other? Was it all together? Second thing, there's no history of any rheumatoid, to rule out rheumatoid, whether the joint stiffness was, there was morning stiffness or no. In the meantime, what has happened to the small joint? So that needs to be clarified here. Okay.
Yes, ma'am.
Because see, you know what? You've given me such a directed history that any examiner would know that you know the case. Okay.
Hello.
Hello.
Hello. Yes, ma'am, I'm able to hear you.
Am I audible? Yeah. So when you give me such a directed case of large joint involvement with nosebleed, with blood investigation, something being done, some counts being low. So first of all, I don't know whether you should be really talking about the diagnosis of dengue in the first place. Even if the parents come and tell you, it is better that you don't tell them that, you know, there was history of dengue with low platelets or low counts or whatever. So otherwise, what happens is that it actually feels as if the case has been fixed. You know the case already. Okay. So that's one suggestion I would like to. I would ask Deshpande sir, do you agree with this or?
You're correct, absolutely correct. She has to describe the pattern of joint pain.
Correct.
I think it is not there in the slide.
Okay. Even if it's not there in the slide, there you have to mention, whenever you have any case of joint pain, whether it is an acute problem, is a chronic problem. If it is an acute problem, is it infective, non-infective? Is it arthritis, non-arthritis? What has happened to the big joints? What has happened to the large joints? What time of the day is the joint pain more? All these factors will add and contribute to the final diagnosis. Okay?
Hello.
Yes, sir.
So what you need to do is, ma'am, log in and then see if your system volume is raised. I think your system volume is low. Or try to connect a headphone to it.
Piyush, can you just mute yourself, please? Yeah. Suparna?
Yeah, ma'am, I was talking to Sarita ma'am actually.
No, but
if you could just sorry about that.
We can hear, no problem. No problem.
Hear your conversation here.
Yeah. So Suparna, can you go ahead, please?
Yes, ma'am.
Yeah.
So now elaborate on the what she has told. You elaborate on the joint pain. Whatever you know.
Yes, sir. The joint pain started 10 days back. It started from wrist joints, both the wrist joints, and then it gradually progressed and it involved the large joints of both upper and lower extremities. It was an additive pattern of joint involvement. Like before the resolution of first joint, the other joint was involved.
Okay.
And there was no involvement of small joints of hands.
Okay.
Was it a fleeting joint pain?
No, sir. There are multiple joints involved at the same time.
At a time. Okay.
At the same time.
So what is the peculiarity of a rheumatic joint involvement? Rheumatic joint involvement and
Sir, in rheumatic joint involvement, it is migratory type of joint involvement. That is involvement of one joint after the other. It involves large joints. It responds well to NSAIDs. And so generally there is a previous history of sore throat or streptococcal infection.
No, we are talking about joint pain, Suparna. When you are talking about joint pain, you have to be very restricted to that question. What are the 3 peculiarities of rheumatic joint pain? Name all 3. What is the type of arthritis? One you said it is migratory.
It is migratory arthritis. It
what is
large
fleeting?
Joints.
What is fleeting? And what is polyarthritis?
Ma'am, fleeting type of arthritis.
Fleeting.
Fleeting
She is
type
fleeting.
of arthritis.
Fleeting. F-L-I-T-T-I-N-G. F-L-E-E-T-I-N-G.
Yes, ma'am. In fleeting type of arthritis, joints are involved one after the other.
So is it one after the other? So is it always ankle followed by knee followed? What do you mean by flitting?
The first joint involvement, the arthritis in the first joint resolves, and after that there is arthritis of the next joint.
Okay, so that is one point, and it is necessary, doesn't follow a pattern. So it's large joint involvement, one joint after the other. It's like, how flit is used for cockroaches, etc. Isn't it? It goes from one to distinct other joints also. That is flitting. Second, fleeting. Fleeting matlab kya?
No, ma'am, not aware.
What is fleet of ships? What is fleet of ships?
Group.
Yes, group. So it is polyarthritis. So more than 2 joints can be involved. More than one joint or large joint. Okay.
Okay.
And what is the other peculiarity which you said already is that response fantastically
responds to NSAID. To NSAID.
Correct. Okay. Can you tell me one joint which always leaves a deformity in rheumatic? Usually rheumatic joints don't leave a deformity, right? No residual deformity.
No.
What is Jacob's arthritis?
No.
See, basically what we wanted to focus on is that even if you have any hematological case or any hepatosplenomegaly case, because of this aspect of joint involvement, your viva can go into any direction. Okay, so you have to be an all-round thinker. You have to think in terms of immunological systems, collagen vascular, hematological system, etc. So Charcot's arthritis is the arthritis which leaves a deformity, and the only joint which actually leaves a deformity is a superior radioulnar joint. Okay, it leaves a deformity. Okay.
Yes.
All right. आगे.
Yes.
हाँ बोलो. So joint pain हो गया. Then fever. Something which is required in fever, which you have not described in your slide. Is there history of rash with fever? Suparna, can you hear me?
Yes, ma'am, I can hear you.
You've not written about rash. You've written about rigors, chills. You've written about the nature of fever, how it is going with spontaneously resolving or not resolving with medications. But what about rash?
Yes.
Is rash important in this case or no?
Yes, ma'am.
Why would it be important? What is the significance of rash in this case?
Ma'am, by rash, I would ask the history of rash to rule out any infective etiology or acute rheumatic fever, or in case as the child has a history of abnormal blood counts, it might be a petechial rash or purpuric.
Okay, so one is petechial rash. If I say it is not petechial rash, any other rashes?
Ma'am, in acute rheumatic fever, there is erythema migrans type of rash.
Can you describe it?
Erythema marginatum, sorry.
Migrans is different. Marginatum. Can you describe erythema marginatum?
Ma'am, pale center and peripheries are erythematous.
Yes.
Erythematous.
And which is brought about by? What is the peculiarity about erythema marginatum? It is brought about by application of heat. Okay.
Yes, ma'am.
So if you raise the temperature of the skin, yes, sir.
Extremely uncommon in because of the complexion of our patients.
It is generally seen in fair-skinned individuals. So in the Western world, you would see it more often. But see, Suparna, your viva will go into the direction that you take the examiner in. So if you're going to talk about rheumatic rash, yes, your viva will go on rheumatic fever. But with this kind of history, what is the more common rash that you can think of? If it is infective. Think of certain infective causes. See, always whenever you're talking about
hey, she is not speaking as she normally speaks. So later, I think depressed नको हो.
नाही डिप्रेस नको हो. डिप्रेस नाही करत आहे बाळा.
झाली असं मला वाटतंय.
मला वाटतं तिला थोडा टाइम द्यायला पाहिजे.
टाइम द्यायला.
Okay, sorry, sir.
I have heard her many times.
तू घाबरू नको बेटा, मी तुला डिप्रेस नाही करत आहे. टू से इज दॅट तू जशी वायवा नेशील ना रजा तशी ती वायवा जात जाईल. त्यामुळे तू पटकन जर रोमॅटिक फीवर बोललीस तर तुझी पूर्ण वायवा रोमॅटिक फीवर वर जाईल. आणि काय टेक्निकली यू नॉट प्रिपेअर्ड फॉर रोमॅटिक फीवर ऍट द मोमेंट. ओके नाही? त्याच्यामुळे स्टिक टू इट. आता तू डेंगीला प्रिपेअर होतीस की नाही? तू म्हणलीस त्याचा डेंगी डायग्नोसिस होता.
Yes, ma'am. In dengue fever, there will be blanching type of rash.
मग ते टॉक अबाउट इन्फेक्टिव्ह कॉजेस. सो आता एक 4-5 इन्फेक्शन सांग ना ज्याच्यात रॅश आहे आणि फीवर आहे.
Yes, sir, ma'am. In dengue, there is a maculopapular rash, which is blanching type, which is seen on trunks.
Okay.
Then, I mean, typhoid fever, but there will not be any joint involvement in typhoid fever.
अजून कुठे रॅश? तुला एक ॲक्रोनिम सांगू का रजा मी? व्हेरी सिक पीपल नीड डबल रेस्ट. माहितीये का हे काय असतं?
येस.
काय असतं? व्हेरी सिक पीपल
द नंबर
डबल रेस्ट म्हणजे काय? The
Ma'am, the
day
number
of
of
rash,
day on
the
which the day of
rash.
rash as per the
Correct.
illness.
मग ते सांग ना, तू मला ते 8 सांग ना डेज तू. फर्स्ट डे रॅश कशात असतो? व्हेरी म्हणजे काय?
varicella.
व्हॅरिसेला.
Varicella.
हा, सिक
Varicella.
म्हणजे काय? हा, एस म्हणजे काय आहे? सिक, है ना? सिक कशात होतं? सिक एस, सेकंड एस कसं? स्कारलेट फिवर. ओके,
Scarlet fever, yes.
ओके. तिसरा पीपल पी पॉक्स. आता दिसत नाही पण पॉक्स.
Smallpox.
हा, said very sick people must fourth and fifth day rash कशात असतो?
Measles.
व्हेरी गुड. मीजल्स.
Measles.
टी म्हणजे काय? टायफस.
For typhus fever.
टायफस. टायफॉइड म्हणू नको. टायफॉइड मध्ये रॅश खूप
Typhus
कॉमन
fever.
नसतं.
Yes, ma'am.
टायफस.
Yes, ma'am.
And
Typhus.
double D is seventh day rashes. D is dengue.
Dengue fever.
हा, आणि
Yes, ma'am.
R is rubella.
Rubella. Yes, ma'am.
लक्षात राहील?
Yes, ma'am.
म्हणजे फिवर विथ रॅश ना काय होतं सुपर्णा, इट्स मोर ऑफ एन युजी क्वेश्चन. पण तिथे जर गडबड झाली ना तर मग
Yes.
गडबड होऊन जाते
Yes.
DNP ला स्पेशली. ओके.
Yes, ma'am.
So
Yes,
आता this is as far as UG's level is concerned. Can you tell me some other non-infective causes of fever with rash?
Ma'am,
Yeah,
juvenile
patient-
rheumatoid arthritis.
Very good. So
It
one
can
is
be in
autoimmune.
acute phase. There is evanescent rash. In SLE,
Yes.
there is malar rash.
Very good. Female child आहे का? Male child आहे?
A female child.
Yeah. So SLE
Nine.
सांगायची गरज आहे. Okay. So one is rheumatoid, second is SLE. Any other causes? आता सध्या होऊन गेला. आता होऊन
Ma'am,
गेला
PIMS.
पेशंटला.
Post-COVID PIMS.
Post-COVID.
may
So
present with
Kawasaki
rash
PIMS
and
you should
fever.
always talk. Okay. आणि
Another.
काय आहे बघ, कुठलाही डिझीजचा जर आपण
in dermatomyositis.
व्हेरी गुड. Dermatomyositis you can have.
Gottrin papules medicine.
And why aren't you talking of something simple? Can it be drug rash?
Yes, ma'am. Drug-induced rash can be.
Yeah. Okay. चल आगे बढ़ो. So rash is
Yes,
important in this case. Sandeep sir, you want to say something?
Yeah. So no, I just want to ask. You have mentioned without chills or rigors. How does it help you?
Sir, in the chills and rigors will be seen in cases of bacteremias or infections like malaria or infective etiologies.
Okay. So
If it is malignancy or rheumatic type of etiology, there will be continuous fever.
correct. That's right.
Which is the immunological fever which will give you rigors? Infective आहे पण immunological mechanism मुळे rigors येतात त्यांना.
Okay.
Something to do with the heart?
Yes, infective endocarditis.
Yes. So infective endocarditis मध्ये you can get because of infected emboli.
Emboli.
Okay.
Release
Yeah.
of emboli.
Okay. Yeah. ठीक है. आगे बोला.
Ma'am, in negative history, there is no history.
Now, I just wanted to cheer you up. You are doing good. Relax.
Yes.
You will not get such a sweet examiner like Sampada ma'am and Bartakke sir, है ना? So chill,
Yes,
just,
ma'am. Yes,
so,
ma'am.
है ना? एकदम cool. Don't tense, है ना? They are
Yes,
just
ma'am.
like your institute
Yes, ma'am.
teachers. Now they are just like outside to just expose you to the external examiners. ठीक है? एकदम relax.
Yes, ma'am.
You are
Yes,
doing
ma'am.
good. Okay? Yeah.
Yes, ma'am. Yes,
Okay.
ma'am. There is no history of sore throat, cough, or cold. There is no history of vomiting, loose stools, pain in abdomen, or ear discharge. Ma'am, I have asked this history to rule out any infective focus of fever, like focus of infection. There is no history of any abnormal movements or rashes. There is no history
एक
of
minute.
migratory
Suparna,
arthritis.
why have you
Yes,
looked
ma'am.
for abnormal movement study?
Ma'am, to rule out acute rheumatic fever, like
But
chorea.
acute rheumatic.
Acute.
So
That will come later.
one thing. Suparna, a coriform arthritis, a rheumatic arthritis will never have chorea. Please underline this in red, blue, green, yellow.
Yes,
Because rheumatic arthritis is one of the most painful arthritis. So obviously coriform movements will not be possible. A. And B
Yes,
reason is that in the first 2 weeks,
it comes late.
and this will come late.
it-
By
it-
then
it
arthritis
comes late
is
in the
already
course.
gone.
It
So when
Yes, ma'am.
it is written in the void that it is God's grace that we don't have chorea and arthritis together.
Together. Yes.
It's a void madla वाक्य.
Yes, sir.
So please हे त्याच्यात टाकू नको because then you will unnecessarily invite questions.
Yes,
if you have to have a diagnosis where you will have abnormal movements also joint pain, hepatosplenomegaly.
Yes.
What it could
Yes.
be?
What could it be? And a male child. We give you a hint. Yes. Something to do with the liver.
Wilson's.
Yes.
Joint
Yes, you can-
involvement.
Any
Yes.
malignancy?
Any malignancies? Wilson's, yes, accepted. Any other malignancies?
No, ma'am.
Sandeep sir.
Yeah, neuroblastoma.
Neurobla-
Usually opsoclonus
Opsoclonus myoclonus.
Opsoclonus
no?
myoclonus.
can be
Yes, ma'am.
associated.
Okay.
There is no history of migratory type of arthritis. There is no history of morning stiffness associated with arthritis. No history suggestive of any swelling in the neck, axilla, or inguinal region. There is no history suggestive of other bleeding manifestations like hematuria or hematochezia, melena, easy bruising, or no history of gum bleed or other mucosal bleeds. There is no history of contact with pets or farm animals or ingestion of unpasteurized milk. And there is no history of Cox contact.
Why have you asked for pets or farm animals?
Ma'am,
Which
rickettsial fevers. Ma'am, rickettsial fever presenting with fever and joint pain because there is history of prolonged fever.
Yes, so for prolonged fever, rickettsial fever presenting, but rickettsial fever with bleeding manifestations?
No, ma'am.
So rickettsial
What
fever,
else?
yes.
What
Which
else?
other
Another cause
disease?
of prolonged fever?
Brucella, I have asked unpasteurized milk to rule out.
But brucella never causes bleeding manifestations, dear. So which is the other disease that you should talk about when you're talking about, when you've mentioned, you obviously will have that in mind. One is rickettsia, you said that, okay. More than that?
Yes. No, not. No, ma'am, I'm not able to.
Okay. I tell you, after the rains in Mumbai.
Leptospirosis
Yes,
is one
yes,
of the
yes,
leptospirosis.
leptospirosis. Okay, fine.
Any
What
travel
is the travel history? That's what sir asked.
No, sir, no history of travel.
Why would it be important? So any infection which comes with joint pains, maybe fever, and maybe prolonged history, maybe prolonged for months.
No, sir. Travel related.
Lyme's disease.
Lyme's disease.
Yeah.
Lyme's disease.
Although it is, I think it is still some rarely seen even in India, but more common in other parts of the world.
More common in Western countries.
Western countries.
Yes.
So, for a simple question, can you tell me the definition of contact? You said history of Cox contact.
Cox contact, yes, ma'am. Ma'am, any close contact with family member who has
how many hours in a day, days in a week, and
no, ma'am, I'm not able to remember.
Please, all of you all, whoever the PGs who are listening to it, these are simple definitions which can be asked to you जब examiner को time pass करने की इच्छा होती है तब. So especially when you say, so it's more than 3 hours in a day, at least 4 times in a week, that would be labeled as Cox contact. No, the contact definition, this is Park's definition for any contact. And the revised NTEP has given a clear-cut definition of Cox contact in this National Tuberculosis Elimination Program अभी जो आया है ना, उसमें उन्होंने दिया है definition. So please go through all of those definitions, okay?
Yes, ma'am.
Yeah, आगे.
Ma'am, there is no history of recurrent febrile illnesses or infections in the past. There is no history of previous hospital admissions or any chronic illness or medications in the past. There is no history of previous blood transfusions.
Why medication? Which? Can medications cause joint pains? Any example, if they can?
No, sir.
So, yeah, voriconazole can cause, prolonged use of voriconazole can cause joint pains. And even sometimes rifampicin for long time.
Rifampicin induced.
Okay.
Yeah.
Okay.
In family history, she's a firstborn of a non-consanguineous marriage. She has a 5-year-old younger brother who is alive and well. There is no history of any chronic illness in the family, no history of blood-related disorders or transfusions in the family, no history of arthritis in the family.
Okay. Okay.
Okay.
Go ahead.
In birth history, she is a full-term LSCS-born child. Indication for section was non-progress of labor. She cried immediately after birth, and there is no history of NICU stay. She is developmentally normal for her age. She has received all the vaccines till age as per the national immunization schedule.
How old is she, you said?
9-year-old, ma'am.
So which is the last vaccine she would have taken according to the national immunization schedule?
Ma'am, at 5 years, she has taken a DPT booster. And she was scheduled for next TT at 10 years of age.
Okay. Okay.
Just one more point, in family history, whenever there is arthritis, you should ask history not only of arthritis in the family, but also psoriasis or inflammatory bowel disease in the first degree relatives. That may be important.
Okay.
Or a renal disorder also.
Yeah.
For that.
Yes, ma'am.
Okay.
In dietary history, her calorie intake is 1700 kilocalories. Expected is 1800 kilocalories with a deficit of 100 kilocalories. There is no protein deficit in the diet. Should I start with examination?
Yes. Okay, but what do you think after the yesterday history? Just summarize, what do you feel that this case is on?
This is a 9-year-old female child with history of fever for a prolonged fever of 1.5 months. There were 2 episodes of fever and polyarthritis for last 10 days with history of spontaneous nose, like bleeding tendency, facial puffiness, and there is history of significant weight loss, 3 kgs in last 15 days.
So
at the end of my history, ma'am, it could be, I would like to give DDs for the presentation. It can be a connective tissue disorder like acute presentation of juvenile rheumatoid arthritis or SLE, or malignancy like leukemia, or infective etiology for the fever and joint involvement.
So which infective etiology?
Ma'am, as the fever is prolonged, it is less likely that it is dengue fever or chikungunya fever. It can be brucella or leptospira or
Why can't it be chikungunya? Why can't it be chikungunya?
Ma'am, there is a predominant arthritis in, arthralgia in chikungunya rather than arthritis.
But from history, how do you know there is no arthralgia, there's arthritis? What are the pointers indicating arthritis?
Ma'am, arthritis is a subjective phenomenon. There is a joint pain along with redness, swelling, tenderness of the joint, and increased heat in the joint. And arthralgia is pain in.
So according to you, it is an arthritis. It is not an arthralgia.
Yes, ma'am, it is arthritis.
So answer sir's question. Do you feel you want to change the order of this differential diagnosis, or you want to keep it the same?
Connective tissue disorders and malignancies would be above, and infective etiologies would be
one
later.
of them out of connective tissue disorder and malignancy. Which one? And you should justify.
Malignancy.
Okay.
Sir, I would put malignancies above because there is prolonged fever along with joint involvement, and there is history of bleeding and weight loss.
Hmm.
Mhm.
Hmm. So you want to keep
And
malignancy first right now?
first, yes, ma'am.
Okay.
Okay, fine. Okay, go ahead. General examination.
On general examination, the child was conscious, oriented to time, place, and person. It is a sick-looking child. Child was febrile, 100.4 Fahrenheit in right axillary temperature. Pulse rate is 104 per minute. It is regular, or peripheral pulses are well felt. There is no radiofemoral delay. Her respiratory rate is 20 per minute regular. Blood pressure is 104 by 64 millimeters of mercury in right arm in supine position, which is near 50th centile for her age and height. Her pulse oximetry saturations were 98% on room air.
Suparna, if I say I don't agree with the respiratory rate with that edema coming up, you said there was periorbital puffiness.
There was
Didn't you mention?
periorbital puffiness, yes, ma'am.
Yeah. So do you agree with that respiratory rate of 20?
Um,
You have a heart rate in this child of 9 years of
9
more than
years.
100. Okay. So can
Yes,
you
ma'am.
justify the heart rate of 104 right now?
Ma'am, on
With
further
those vitals?
examination, she was
No, forget the
pale.
further examination. I'm talking about till now. Do you justify the temperature, pulse, and the respiratory rate?
Mm,
Can she have a pulse of 104
yes.
from these vitals? What can contribute to the tachycardia right now?
Fever.
So the pain, she has joint
No, this
pain.
just before the pulse, what have you written, Divya?
Fever.
She has a fever of 104 Fahrenheit.
So by how many degrees rise has it happened over the baseline?
Ma'am, 2 degrees above, 2.5
so,
degrees above
yeah,
the
two
baseline. So
degrees. So
pulse
what
should be
would
more than 20.
Okay, so can you justify 104 pulse right now with that? Yes or no?
Yes, ma'am. Around 80
Yes.
to 100 will be
Okay,
a
so you can
normal
justify
pulse
it.
rate.
Fair. Okay.
Yes,
What
ma'am.
about the respiratory rate? You from the beginning you're talking about bleeding, you're talking about bleeding manifestation, diathesis, and then you're
Yes,
talking
ma'am.
about periorbital puffiness. Okay.
Yes,
So what are
ma'am.
you trying to tell me? That probably the child has anemia?
Yes, ma'am. She
Yeah.
was
So
pale
if
on
this
very
child is
pale on
anemic,
examination.
is the child in failure or no? Because nowhere in your history I got a feeling that the child was in failure.
No, ma'am. There
Okay.
were no signs of failure.
So there is no signs of
No
congestive
signs of
cardiac failure
failure.
on history also.
No,
So then
ma'am.
the respiratory rate can be justified. No, why I was
Signs,
asking is there
signs or symptoms. History में signs कैसे आएगा?
There were no
नहीं साइंस
symptoms
में
of
सिम्टम्सच म्हणलं
failure.
सर
History में symptoms
चुकून
आएंगे ना.
हाँ
Science
Yes,
now
नहीं
is there.
साइंस फक्त correlating the science of general examination with the symptoms on history. That is what I'm trying to get. Okay. So you can tell the examiner
Yes, ma'am.
yes that there are no
Yes, ma'am.
symptoms of CCF on history, so the respiratory rate
CCF
can
on
be
history.
20.
Probably because of
Yes,
the
ma'am.
joint pains, her activity has been restricted.
Yes.
Restricted. Yes,
So
ma'am.
not feeling the breathlessness and whatever.
Normally, if the child is very
Sick.
pale, anemic, sick looking,
Yes, ma'am.
possibility of that respiratory rate is a little low. Okay, that's what I
Okay.
wanted to say. Okay.
Okay. Yes, ma'am.
Yeah. All right.
Coming to the sorry, just about the pulse we discussed so much. Where do you see relative bradycardia?
Typhoid fever.
Correct.
And anything else?
But that is a peculiarity. Relative bradycardia is not very marked in children. That is the difference between adult
Correct.
typhoid and
Enteric fever.
pediatric.
So
Adult and
adolescents-
pediatric. There are few differences in adult typhoid and pediatric typhoid. Pediatric
Yes, sir.
typhoid, you have a relative bradycardia, but not as
Yes,
marked
sir.
as the adult.
Okay. And
Yes.
where else can you get bradycardia in spite of fever? It's not relative though, but any other?
Factitious fever.
Factitious fever मध्ये तर feverच नसेल ना.
Yeah.
I'm talking about fever आहे, infective etiology आहे, but relatively bradycardic असतो. Where will you get it?
Ma'am, SA node.
हार्ट ब्लॉक म्हणायचं का तुला?
हा,
हार्ट ब्लॉक
Heart block म्हणायचे
blocks.
का? पण मग ब्लॉक्स मध्ये
नाही.
फीवर कशा कुठल्या कंडिशन मध्ये आता परत तो प्रश्न सुपर्ण होईल की कुठल्या कंडिशन मध्ये हार्ट ब्लॉक
Yes,
होतो.
yes, ma'am.
Unnecessary don't dig your own grave over there.
Yes, ma'am.
What we are asking you is that कुठल्या सिम्पल एक्झाम्पल ना इन्फेक्टिव्ह हेपॅटायटिसच्या ऑब्स्ट्रक्टिव्ह फेज मध्ये काय होतं?
Yes, ma'am.
You have bradycardia,
Early
right?
bradycardia.
So
Yes,
talk
ma'am.
about infective hepatitis. No, it's much more easy to define and answer questions if you have questions on
Yes, ma'am.
hepatitis.
Yes,
Okay.
ma'am.
तुम्ही जर ब्लॉक्स बेक्स आणि एव्ही नोड्स आणि ह्याच्यामध्ये गेला ना अजून
Hmm.
अवघड होत जाते बाय. ट्राय टू कीप युअर वायवा
Yes,
व्हेरी
ma'am.
सिम्पल. ओके.
Yes, ma'am.
ऑल राईट. ठीक आहे. पुढे.
On general examination, there was pellar.
Hmm.
In the conjunctiva, oral mucosa, nails and palms were pale. There is facial puffiness. There was bilateral pitting type of pedal edema up to ankles. There is no evidence of icterus, lymphadenopathy, cyanosis, or clubbing. There is no evidence of petechiae, purpura, or ecchymosis on examination.
So describe
Okay.
the facial puffiness little more. Was it
Sir, whole
were
of
there
the
engorged
face
neck
was
veins?
involved. No, sir.
There was
There were no, sir. There were no engorged neck.
Okay, so
Okay.
you
And what time of the day the mother noticed that the
There is
facial
no
puffiness was?
diurnal. There is no diurnal variation in facial puffiness. It was same throughout the day.
Okay.
okay.
Just a quick revision, Suparna, you've gone through your IMNCI modules because if you go to a government medical college, they'll be asking you about IMNCI. So can
Okay.
you classify pallor by in this patient according to your IMNCI module?
She will not be knowing.
सर पण त्यांना असं इफ ते गो टू अहमदाबाद बीजेएमसी अहमदाबाद वगैरे ते विचारतात ना त्या लोकांनी लिहिलेले आहेत ना मॉड्यूल्स ते सो आय थिंक when they are appearing for DNB, you have to know all those guidelines of the government guidelines at least, you know.
Yes, ma'am.
So
Yes, ma'am.
pallor चे 3 grades आहेत. So please all of you, all the residents over here, please get your
Yes, ma'am.
SAM modules and facilitated newborn care modules,
Yes.
and please go through it and learn them by heart.
Yes, ma'am.
That's a simple advice I can give you. Okay, because
Yes, ma'am.
government medical colleges still are following these guidelines. Okay.
Yes, ma'am. Yes,
All
ma'am.
right. Chal.
In anthropometry, her weight is 24 kg, which is between 25th to 50th centile for her age. Height is 135 centimeters, which is between 50th to 75th centile for her age. This is as per the IAP charts, IAP growth charts.
But why are you following IAP growth charts?
Ma'am, she's 9-year-old, above 5 years of age. IAP growth charts.
IAP growth chart कुठे फॉलो करतात? तुमच्याकडे it is better that you follow the international CDC growth
Internet.
charts there
Okay.
because
Yeah, generally,
Yes, ma'am.
but above 5 years, you
Above
follow
5
Indian
years.
IAP growth chart.
Ha.
Below 5 years, WHO chart.
ह्या पण सर
That is the
WHOचे पण
standard.
आता आलेत ना नवीन वाले जे. Why don't you follow those?
Yeah, but above 5 years, we follow IAP charts. Yeah,
Yeah.
everywhere, if you
Yeah.
see the charting, there is a dip, एक स्टेप डाऊन येतं 5 वर्षानंतर आणि खालच्या लेवलने चार्ट वरती जायला लागतो परत. Because up to 5th year there is a WHO, and at 5 years onwards we use Indian charts, Indian IAP, खाडिलकर आणि यांनी जे केलेले आहेत खाडिलकर charts. In short,
Can you interpret this weight and height, Suparna? Can you interpret this weight and height?
Ma'am, her height is as per her. It is between 50 to 75th centile, so there is no stunting in height.
Yes.
Her weight is between 25th to 50th, so it is slightly less for her age. It is slightly below the 50th centile.
So what is your interpretation? So what kind of
the
thing has
wasting,
happened?
acute type of
Yes.
malnutrition.
So this is a problem which is
acute
more of an acute than
acute
a chronic
wasting,
problem.
chronic
Okay.
problem.
Yeah.
Yes, ma'am.
Yeah. Okay. Go ahead.
In head-to-toe examination, there is facial puffiness. In eyes, the conjunctiva is pale. Ear, mouth, and oral cavity appear normal. The neck, abdomen, trunk appears normal. In upper limb, the left elbow joint is red, swollen, and tender with the limitation of range of motion. Right elbow joint appears normal. Both the wrist joints are swollen and tender. Small joints of hands appear normal. In lower limbs, there is bilateral pitting edema up to ankles. In bilateral ankle joints are red, swollen, tender with limitation of range of motion because of pain. Both knee joints appear normal, and there is generalized bony tenderness.
Okay. What do you expect in the oral cavity?
Ma'am, oral ulcerations or mucosal petechiae, gum
Okay, one
bleeding.
is mucosal petechiae, gum bleeding. Okay, what else would you expect?
Oral ulceration, thrush can be there.
Okay, oral thrush. What else? In the throat?
Enlarged tonsils if it is lymphomas.
Okay, what else? What happens in leukemia?
मेम्ब्रेन दिसतं का? मेम्ब्रेन कुठे?
Tonsillar membrane.
कुठल्या
white
मेम्ब्रेनचं टॉन्सिलर मेम्ब्रेनचं डीडी सांग ना.
It can be diphtheria, leukemia, Epstein-Barr virus infection, candidiasis.
Yes.
It can be pustulate, not pustulate. Tonsillitis, acute tonsillitis with formation.
Granulocytosis.
Granulocytosis.
Yeah. Okay. This is a 9-year-old child. Will you not like to do the SMR?
Yes, ma'am.
Ideally, if it is above the age of 8 years in girls or 8 to 9 years, you should be doing the SMR also.
SMR
Never forget
staging.
doing the SMR staging. Okay?
Yes, ma'am. Yes.
So she was pre-pubertal, pubertal. What is it?
Ma'am, pre-pubertal.
She was pre-pubertal.
Pre-pubertal.
Okay. Okay. Go ahead.
Suparna, what about that ankle edema? Do you think it is edema or edema due to arthritis when ankles are involved?
So there was actually both. There was pedal edema also, but ankle arthritis was also there.
You just mentioned, no, Suparna, that the ankle edema extended right up to the shin,
up
right?
to the ankles.
So
Yes,
tell
ma'am.
sir that it extended right up to the shin. So it was
The
edema.
edema
It was
was
not...
up to. Yes, ma'am.
What about JVP and neck veins?
So the neck was normal on examination.
No JVP?
No, ma'am, it was normal.
Okay.
Neck veins were not prominent.
Sorry, sir?
Neck vein prominence was there or not?
No, sir, neck veins were not prominent.
When she examined, later on, when the patient got admitted, and we are not discussing the diagnosis right now.
So how do you explain this pedal edema and facial edema? Is it related to basic disease or something else?
Suparna, if you have a child who has a periorbital puffiness, who's very pale, and you want to know whether he is in impending failure, what is the test you will do? Which will probably tell you that this child in the next 24 to 48 hours is going to be in fluid overload.
Ma'am, hepatojugular reflux, like signs
yeah,
of
reflux. So did you do the HJR? That is one test which will really get out the hidden features in this child. Because if the child is so pale up to the palms and soles, it is very likely that this child will go in fluid overload later on.
Yes, ma'am.
Okay, the primary diagnosis, Suparna, you know, everybody knows what is this. This is probably malignancy. In that view, how will you read this facial edema? Any specific condition which comes to your mind?
Sir.
I give you a hint, Suparna. There is a malignancy. There is only facial puffiness, nowhere else. Supposing forget the other edemas, there is nowhere edema. Okay. And there's only facial puffiness. So can you think of a diagnosis? That is what sir is asking. Yes.
Mediastinal mass.
Very good. Mediastinal mass is excellent. What is it called?
SVC syndrome.
Correct. Superior vena cava syndrome.
Superior vena cava.
Yeah. Okay. Mediastinal syndrome. Okay. Fine. Go ahead.
Yes, in systemic
where do you
examination,
look for bony tenderness, Suparna? You said there was generalized bony tenderness. There's nothing like generalized bony tenderness. You have to look for bony tenderness at only two sites. Can you tell me those two sites?
Ma'am, shin of tibia.
is one.
While
Correct.
looking for pitting edema, it was tender.
No, chin of tibia is different and pitting edema different. Where do you look for pitting edema? गडबड करू नको तू. Pitting edema कुठे बघतो आपण?
And the intermetatarsal spaces, ankles, no, ankles malleolus आहे इथे.
Malleolus तिथे बघतो का त्याच्या थोडं वरती बघतो? Go back to your Hutchison.
Yes, ma'am.
Okay. And where do you look for bony tenderness? You also look for bony tenderness in the lower limbs, but the places where you look for the two are different. Don't say it in the same breath. Okay?
Okay. Yes, ma'am.
And where else do you look for bony tenderness? Ankle वर समजा नाही तुला edema खूप आहे नाही बघता आला. कुठे बघणार अजून bony tenderness? Normally कुठे बघतो बेटा?
No, ma'am.
On the sternum.
Sternal tenderness.
Sternal pressure. Okay?
Yes, ma'am.
आगे.
On per abdomen examination, on inspection, there was some fullness in the upper abdomen. Respiratory movements were normal. Umbilicus was central and inverted. There are no scars, dilated veins, visible pulsations or peristalsis in the abdomen. On palpation and superficial palpation, the abdomen is soft and non-tender. In deep palpation, liver was enlarged 8 centimeters below the right costal margins. It is firm in consistency and non-tender liver. Liver span is 15 centimeters. Spleen is 5 centimeters enlarged below the left costal margins, firm in consistency. Kidney and bladder were not palpable. Abdominal girth 56 centimeter at the level of umbilicus. On percussion, there is tympanic note all over the abdomen except for the region of organomegaly. There are no signs of free fluid in the abdomen. On auscultation, bowel sounds were heard in all 4 quadrants. Genitalia and hernial sites appear normal on examination.
Spleens are bugs are palpation. Go back to your splenic palpation.
Yes,
is it complete? Go back to your liver palpation. There are 8 headings under which the liver is always mentioned. दिसतायत 8 तुला लिहिलेले त्याच्यात? या खूप basic गोष्टी आहेत. These are UG things which you can't go wrong, even if we know the diagnosis. So what are the other things which are missing in your liver palpation? Do you think the sharp
surface
borders are sharp? See, first of all, sharp borders कुठे येतात बेटा? Where will you get sharp borders? What has happened to the edge? What has happened to the left lobe? What has happened to the surface? What has happened to the pulsatility? What has happened? The tenderness you mentioned. ते बाकीचे points कुठे आहेत बरं याच्यात?
Yes, ma'am. I should have mentioned.
Okay. So your liver palpation has. So what is the significance of left lobe of the liver being palpable? When do you get a left lobe of the liver which is palpable? Where do you get the left lobe palpable? कुठे येतो बरं left lobe palpation? Epigastric region.
Epigastric region. Yes, ma'am. Epigastric region.
So when you're proceeding towards the epigastric region, you'll get a left lobe palpable, which is palpable in which 2 conditions? One is chronic liver disease, and second is storage disorders. Okay, so these are the 2 conditions where you will always get a left lobe of the liver palpable, especially in these huge hepatomegalys. You should always look for the left lobe. Okay,
left lobe. Yes.
Sharp borders usually cirrhosis मध्ये येतात.
Yes, ma'am. Liver cirrhosis.
So please don't talk about sharp borders. Okay, you talk about rounded edges. Firm consistency is fine, but talk about rounded edges.
Rounded
sharp
edges.
borders. Okay.
Yes, ma'am.
So that's an incorrect term to be used because there are some examiners who may not like these terms used wrongly. Okay, especially उत्तरेकडे थोडासा हा त्रास होतो. Okay.
Okay. Yes.
All right. Spleens are bug baro. There's nothing about the notch which is being mentioned.
Ma'am, it was only 5 centimeters enlarged below.
So what do you mean? You feel like 5 centimeters? Are you really sure that in a 5 centimeter spleen a notch will not be palpable?
She could not appreciate.
I could not palpate the notch, ma'am. That's why
she could not appreciate.
I could not appreciate.
But normally you should talk about it, okay? Because again, a notch is lost in 2-3 conditions. Where is the splenic notch not felt? One is in malignancies. Okay.
Malignancy. Yes,
Second, storage. Okay.
Storage disorders.
Yeah, the splenic
Yes,
notch may not be. Can you tell me some causes of huge, massive splenomegaly? Massive splenomegaly.
Thalassemia.
Very good. Yes.
Thalassemias which are long standing.
Whereas? Okay. What happens in certain conditions like malaria?
Yes, ma'am.
Have you heard of tropical splenomegaly syndrome?
Tropical. Yes, ma'am.
Okay.
Associated with fever?
See, Suparna, these are standard questions.
Yes,
so I would request all of you to write down causes of massive splenomegaly, splenohepatomegaly, hepatosplenomegaly. Okay. So these are standard questions with standard answers. So you should not waste time over them. Okay. Causes mighty paije. Then standard answers like a malignancy, a CML, a Pelti's syndrome, portal hypertension, tropical splenomegaly syndrome, and of course thalassemias. These are standard answers which I think you should start off with. So then start off with the one you know the best. Okay.
Yes, ma'am.
Okay. Okay. In which condition the spleen does not go to the right iliac fossa, it goes to the left iliac fossa?
Hello, I couldn't hear the question, ma'am.
See, normally in which direction does the spleen grow?
From left.
Yeah, but where does it go? Normally, if there is splenomegaly, in which direction does the spleen?
Towards the right iliac fossa.
Correct. It goes towards the right iliac fossa. Can you tell me a condition where the spleen does not go towards the right iliac fossa? It goes towards the left iliac fossa.
No, ma'am.
Okay, it is in massive Kala-Azar. Okay, because of the destruction of the ligament. Okay, you sometimes get a splenic enlargement towards the left iliac fossa.
Left iliac fossa. Okay.
Okay.
Yes, ma'am.
So is the spleen tender?
Yeah.
No, ma'am, it wasn't tender.
So what are the causes of tender splenomegaly or tender hepatosplenomegaly?
I'm splenic abscess.
Okay.
Hello.
Yes.
Congestive splenomegaly, splenic abscess.
And
any infective cause? I just mentioned.
In any malignancy where there is a massive spleen, and then they have what they have? Splenic infarcts. Splenic infarcts are extremely painful.
Yes, ma'am.
Splenic infarcts are extremely painful.
Yes, sir.
Okay, so see, remember, Suparna, whenever there is pain, there always has to be either there has to be congestion or there has to be inflammation with thrombosis, microthrombi.
Yes,
then only a condition becomes very, very painful. So either it is congestive splenomegaly or you have splenic infarction because of massive overgrowth of the reticuloendothelial system.
Yes,
okay, and of course, the most painful splenomegaly is also seen in Kala-Azar. Okay. So, Suparna, can you hear me?
Yes, ma'am.
Okay.
Hello.
Go ahead.
Ma'am, examination of rest of the systems was not unremarkable.
Okay.
Now, in the respiratory system, the breath sounds were equally heard on both sides. There were no added sounds. In cardiovascular system, heart sounds were normal, no murmur. And in central nervous system, the patient was conscious oriented, no focal neurodeficit.
What would you have expected in the RS and CVS after 2-3 days?
Yes, ma'am. After 2-3 days, the patient had fluid overload.
So what would you get?
Because of which she developed bilateral pleural effusion because of fluid overload.
So do you get bilateral pleural effusion because of fluid overload? Do you get pleural effusion because of
Ascites.
fluid?
She developed ascites as well, ma'am.
Tense ascites.
Yes, but then you just said she was in fluid overload, right? She went into fluid overload. Na? So what are the signs of fluid overload?
And there will be edema, tachycardia, tachypnea, a gallop rhythm may be present.
Yes, and on respiratory system examination?
Basal crepitations, bilateral basal crepitations.
Okay, bilateral basal crepitations. If the child is in the ICU, which is the test you will like to do to rule out fluid overload? Bedside, some investigation? If you are in the ICU? Because you all are residents, no? You all are working in the ICU.
She knows what.
Sir. What do you do, beta, in the ICU? I say there is fluid overload. You don't have an X-ray.
Overload or underload to determine whether it is overloaded or underloaded.
You want to know the intravascular compartment, whether it is shrunken or overloaded.
Ultrasound, we can see the IVC collapsibility with ultrasound.
Very good. So you look for the IVC collapsibility. Okay. And can you also measure something? There's one. This is the most commonly used thing. Okay. If you have a central line, what can you do?
Cvp measurement.
So what is a normal Cvp measurement?
8 to 10 is the
normal beta. How do you measure Cvp, Suparna? In a line?
I haven't done it.
Okay. Okay. So what is your diagnosis at the end of it? You've done the entire examination, right?
Yes, ma'am.
So has your general and systemic examination contributed to your history?
Yes, ma'am. There is in examination there is pallor, there is hepatosplenomegaly, there is generalized bony tenderness, edema, and facial puffiness, along with history of fever and polyarthritis. So it most likely point towards a malignancy.
Is there any lymphadenopathy?
No, ma'am. There was no lymphadenopathy.
Okay. So would it have contributed to your diagnosis?
So, ma'am, I would
see. Supposing I have a child, you're thinking of a malignancy with lymphadenopathy, without lymphadenopathy. Does it make a difference?
Yes, ma'am. With lymphadenopathy, it is likely to be lymphoma. And without lymphadenopathy, it can be leukemias.
Okay. So you
so you feel that
in leukemia will not have lymphadenopathy?
There is lymphadenopathy, sir, but
so how the lymph node enlargement will guide you towards a particular malignancy?
Sir, in Hodgkin's lymphoma, it is contiguous lymph node involvement. It starts with one region of the lymph nodes, and then there is contiguous involvement. In non-Hodgkin, there is discontiguous involvement.
Okay. So predominant bulky lymphadenopathy probably, and in isolated either cervical, axillary, probably would point more towards lymphoma, as against small to moderate and generalized pointing more towards leukemia. Again, they can overlap, but generally that is the thing. Can you still defend GIA or connective tissue disorder in this case? After
so it can be systemic onset. It can be systemic onset juvenile rheumatoid arthritis. Because there will be fever, hepatosplenomegaly. And there could be a complication of juvenile rheumatoid arthritis, like HLH could be there.
Okay. So what is it called, more HLH or something else?
Macrophage activation syndrome.
Correct. So do you think that is still possible?
Yes, sir. It can be a possibility.
Okay. And do you still think infections can be a possibility?
Sir, it is less likely that it is infective etiology.
Why? Even infections can be complicated with secondary HLAs, right?
Secondary HLAs, yes, sir.
They can have cytopenias, they can have bleeding, they can have hepatosplenomegaly or lymphadenopathy.
Yes, sir.
So again,
sir, it is a prolonged history of fever, and there was a symptomatic period of 15 days in between the 2 episodes of fever.
So how do you explain that? How does it favor malignancy? It can happen with anything, malignancy, connective tissue.
Yes, sir.
Do you think probably she received something which reduced the fever and joint pains?
Yes, sir. She might have received corticosteroids in her previous admission.
Correct. Can it be tuberculosis, Suparna? Why can't this be tuberculosis?
I mean, tuberculosis, there is low grade fever with evening
Not
rise of
necessary.
temperature.
Not necessary. You can have prolonged fevers, 1.5 month fever with severe pallor, with weight loss of 3 kilo, with hepatosplenomegaly, no lymph nodes again, and you can have HLH coming after tuberculosis. So why can't it be plain simple tuberculosis? In India, you can't keep it out of your differential diagnosis list.
Yes, ma'am. Yes.
Okay.
Yes, ma'am.
All right. So see, basically, when you are discussing a case, don't stick to one diagnosis like malignancy.
Yes, ma'am. Yes, ma'am.
Okay. Okay. So how will you investigate?
Ma'am, initially I'll do basic investigations like hemogram, inflammatory markers.
See, basically, don't use these words, basic, acidic, baseline. Just start off with your list, no? Because we have this habit of saying basic, routine, baseline.
Yes, ma'am.
There's nothing basic, acidic, or routine about anything. Okay.
So, ma'am, hemogram, ESR, CRP, blood culture.
Hemogram may, please do not just say simple hemogram. Always
hemogram
say
with peripheral smear.
Yeah, correct. Use the word correctly. Peripheral smear. What do you expect on peripheral smear?
Ma'am, if it is malignant etiology, there will be blasts present on the peripheral.
Hey, what do you expect in this
typical? There will be anemia. Depending on the severity.
What that's exactly what I'm asking you. You have a history, no, beta. Now you have given me a history.
Hypochromic.
I challenge this is not microcytic hypochromic. Why? This is a normocytic normochromic. Tell me why. Why? Because you told me a absolutely nutritional normal status.
Normal status, yes, ma'am.
You told me her centiles are above 50th centile. She's eating well, diet, there's no deficit. So now why will she have an iron deficiency?
Yes,
of course, prolonged fevers, prolonged infections can cause baseline, but basically it is looking like a hematological disorder where you will expect a
normocytic normochromic.
Okay, so keep your head on your shoulders when you're answering, okay? Yes, so don't say microcytic, ekdam patkan reflexly ko uttar dilcho, okay?
Yes, ma'am. Then ma'am, there can be leukocytosis or leukopenia, both can be seen.
Okay.
So which will
like
favor
this
what?
Time, initially there was leukopenia.
Answer sir's question, which will favor what?
No, sir, I did not get the question.
So you have your three DDs. You just have to say, no.
You have your. See, you gave 3 differential diagnoses to Sandeep sir, right?
Yes, ma'am.
You gave a malignancy, you gave an HLH-like situation, you gave a chronic infection, and you gave an autoimmune.
Ma'am, in HLH there is HLH there is pancytopenia.
Okay, so say that leukemia
there
would
will
be
leukocytosis.
Always? You're right. HLH
not always.
Yes. So which are the leukemias where you will get leukocytosis and which are the leukemias where you will not get leukocytosis? That is my question.
Acute lymphoblastic leukemia and acute myeloid leukemia present with leukocytosis.
Okay.
Always?
Initial phases, there is leukopenia is also seen sometimes in acute leukemia.
So which leukemia will
lymphoblastic
always present as leukocytosis? Which leukemia will never present as leukopenia?
Myeloid.
Which one?
She said myeloid.
Sir,
myeloid, yes.
AML comes with leukocytosis.
No, not always. Okay.
Chronic myeloid.
I'm asking is
CML.
Yes, CML.
CML
CML
is
will never present with leukopenia.
Yes.
Okay.
Okay, what else in hemogram?
Thrombocytopenia will be seen.
You're
Okay.
expecting thrombocytopenia, correct?
Correct.
And atypical cells will be seen on peripherals. Blast cells will be there.
Okay,
So
you will look
are
for blast.
Are they the
Hello?
same atypical lymphocytes and blast?
When do you get atypical lymphocytosis and when do you get blast cells? Is it the same?
Blast cells are seen when there is increased marrow turnover, causing spillage of the precursor forms in the peripheral circulation.
So blasts are basically precursors, right?
Precursors, yes.
So what are atypical lymphocytes? Because you said it in the same breath, no? That's the reason.
Yes, ma'am.
What are atypical lymphocytes and which conditions will you get atypical lymphocytes? You get it on the reports, no? When you see hemogram reports nowadays.
Yes, ma'am.
Which infections will have atypical lymphocytes, Vidya?
Sorry, ma'am.
Is it bacterial infections? Any viral infection will have atypical lymphocytes. Okay?
Yes. Yes, ma'am.
All right. What is leukemoid reaction, Suparna?
Ma'am, in leukemoid reactions, the leukocyte counts are raised above 50,000, but they're not.
Okay. So how do you differentiate?
And the ma'am, when to differentiate between the two?
Hello.
Yeah, bone marrow will differentiate between the two.
So will you always do a bone marrow test in leukemoid reaction?
Not always.
Atake sir, you want to contribute?
Sorry, I miss. I was.
No, I said leukemoid reaction. I thought you wanted to say something. Leukemoid reaction.
So what are the types of leukemoid reactions? So it can be myeloid or lymphoid, right? Myeloid means there are neutrophils, predominantly neutrophils, or sometimes there's left shift and you have myeloid precursors like myelocytes or band forms or rarely promyelocytes. Okay. And lymphoid means you have predominantly lymphocytes in the peripheral blood. So there are different etiologies. Commonest is myeloid leukemia reaction, but you will see lymphoid leukemia reaction in certain viral infections like pertussis or pertussis-like infections.
Yes, sir.
Myeloid, what are the causes of typical myeloid leukemia reactions? Mainly infections, right?
Infections, yes, sir.
Correct. So, including the important one being
Shigella, Salmonella.
Correct. Common infections, but you should never forget tuberculosis.
Tuberculosis. Yes.
Okay, so besides the peripheral smear, what else will you like to do?
Ma'am,
yeah, sorry.
Markers, ESR and CRP, because we have kept connective tissue disorders as one of the differential diagnoses.
Okay. What else?
And blood culture I would send because infective etiology is one of the differentials. Also, for connective tissue disorders, investigations like anti-nuclear antibodies,
which bacterial infection did you keep? Suparna, you said blood culture, no? Which bacterial infection have you kept in mind? Because in your differentials, the bacterial infections never surface. So why blood culture? Which
Brucella, we
Tumor
had
is
kept
there.
Brucella in.
Okay,
And
so
we
you
had
had
kept
said
Brucella as
Brucella.
one of the differential
Brucella is there.
diagnoses.
Yes.
And typhoid fever.
And typhoid fever. Okay.
Yeah.
Okay. Take it. In typhoid fever, will you have such a big liver and spleen?
And
8
joint pain?
centimeters.
No,
And joint pains
joint
and
pain will not
bleeding
be there.
manifestation. So generally,
no, ma'am.
don't unnecessarily in the list. It shouldn't figure out in your first 3-4 investigations. Unnecessary that Viva will go in directions that way. Okay.
Yes, ma'am. Yes,
Okay. So what else will you want to do? तुमने 3 differential रखे हैं ना बेटा? You just tell me ना. Okay, now you said connective tissue.
Ma'am,
So
for
you just said
malignancy.
CRP. No, 1 second, beta. You said CRP and ESR for connective tissue, right?
Connective
As
tissue.
inflammatory markers. Are they the only tests you're going to do for connective tissue? So complete the list.
No, ma'am. Rheumatoid factor, antinuclear antibody, antinuclear cytoplasmic antibody. For SLE, anti-dsDNA, anti-Smith antigen. Anti-Rho and La antibodies.
Which is the most significant test for SLE?
Anti-dsDNA antibody is the most specific.
That is ठीक है. dsDNA करते हो. What else?
No, ma'am.
What is anti-CCP?
Anti-cyclic cetylated peptide.
That is the most specific test that you do for lupus nowadays. Okay, fine.
Yes,
so this is when you're doing connective tissue, then complete the entire list of connective tissue. Don't make it haphazard. थोड़ा इधर बताया, थोड़ा उधर बताया. Okay.
Yes.
Oh, fine.
So what will be your finding if it is systemic onset GI in investigations?
Sir, in systemic onset GI, in hemogram there will be thrombocytosis. Leukocytosis may be seen. ESR is raised above 20.
And WBC count?
WBC, SOGI, WBC count, how it is? It will be more, no?
Leukocytosis, sir.
Neutrophilic leukocytosis.
Neutrophilic leukocytosis.
And what? And ESR you said about 20. No, it will be very high, no?
Very high. Yes.
About 40, 50 चा वर है तो ESR.
Yeah.
Yes, sir.
And what suddenly suppose the ESR drops. Okay, so it is 100, and then you are monitoring, and after days the ESR drops. What does it signify in SOGI?
Or platelet drops suddenly.
Platelet drops. Along with that, ESR
in SOGI,
drops.
suddenly platelet drops.
Sir, macrophage activation.
Yes,
correct.
Absolutely.
Correct.
Macrophage
Why does the
activation,
ESR
sir.
drop? What is the reason for?
Pancytopenia.
No, but that
fall
is
in
not the
ESR?
cause. ESR क्यों होता है?
Because the fibrinogen is
Fibrinogen,
less.
hypofibrinogen. Yes,
Correct.
sir.
So Role formation decreases.
Yes, sir.
Okay. So this is about this thing. And what about malignancies? What will you want to do for malignancies?
Ma'am, bone marrow aspiration and biopsy, and sent for flow cytometry, fish
Bone
panel.
marrow aspiration भी करोगे और biopsy भी करोगे. What are the indications of bone marrow biopsy? See, don't use these terms interchangeably.
No, we do both. That's why she's telling.
Do it together.
Yeah.
In our place, we do both for diagnosis of malignancy. So that's why she's telling. In one go, we do bone marrow biopsy and aspiration.
So let's put it other way. So why do you have to do bone marrow? Which are the conditions where you have to do bone marrow biopsy?
Normally, in leukemia, a biopsy may not be needed. No, in which conditions will you like to do a biopsy? Generally, these are very adult.
Of the bone marrow.
Architecture. What will
Just tell
happen
me
in certain conditions to the bone
Filtrative
marrow?
disorder.
Yeah, which disorder?
What are the causes of dry tap?
Myelodysplasia, red cell aplasias, aplastic
Dry tap.
anemias.
Dry tap.
Dry.
Myelofibrosis.
Fibrosis. Okay.
Correct. And
So,
Hello.
myelofibrosis
Hello,
and
you must have done that, found out that it's marrow is difficult to aspirate. Myelofibrosis is rare in children.
Rare in children, yes, sir.
So whenever there's marrow is packed, okay, with sometimes with malignancy, leukemia, there also sometimes you can get dry tap.
Right. Yes, sir. Yes.
Okay, so which conditions where you have to do biopsy? You cannot base your diagnosis on just aspiration.
No, sir.
You just now said, na. So myelofibrosis, you cannot diagnose on aspiration.
Aspiration, yes, sir.
Aplastic anemia, you cannot diagnose on aspiration. For that, you
Yes,
need
sir.
bone marrow biopsy.
Yes,
Okay.
sir.
okay. So, what do you expect on a bone marrow aspiration?
Increased number of precursors, leukocyte precursors, and there is suppression of other cell lines.
Okay.
So here, in this case, there is significant hepatosplenomegaly, right?
Hepatosplenomegaly.
So what
yes,
do you
sir.
expect on bone marrow? That marrow will be almost replaced by
malignant cells, blast cells.
By blast cells, almost replaced. There will be hardly any normal
cells. Yes, sir.
precursors.
Okay.
So
what are the other uses? Sorry. No, sir.
You
Please
can.
go on. No, sir. Sang.
No.
Some mute झालाय sir तुम्ही.
Mute झाला mute Sandeep.
Hello.
Now you are audible.
Yeah. So I was getting a call. Sorry. So so next is what are the different types of leukemia that you know of, and how do you diagnose them?
So they are divided into lymphoid leukemias and myeloid leukemias.
Okay. So in children, which is more common?
Leukemia, chronic lymphoid leukemia.
Sorry,
CLL is chronic lymphoblastic leukemia, but it is rare. No, sir, it is not commonly seen in children. It is an incidental diagnosis for many times.
No, what is the commonest leukemia in children?
Acute lymphoid leukemia.
Acute lymphoid leukemia. Now, supposing this child comes to you with ALL and he starts suddenly vomiting, what will you think of? Vomiting, high-grade fever. Suddenly there's headache and this child starts vomiting.
Ma'am, central nervous system spread of
okay, CNS.
Leukemia, CNS spread of CNS metastasis.
Okay, so correct.
Is it much?
नहीं sir, बोलो. Sandeep sir, please go.
Sorry, again I lost. So what were we discussing? CNS involvement.
CNS involvement in leukemia.
Okay. Where else is what are the sanctuary sites in ALL? One is CNS, the other is?
Testicular involvement in male children.
Correct. So you should always examine testes in any suspected case of leukemia.
Yes, sir.
Okay. So ALL, how do you diagnose whether it is ALL or AML?
Flow cytometry is done to see CD markers.
Before that, directly you'll go for flow cytometry. Before that,
Sir, on bone marrow, whether there are lymphoid precursors or myeloid precursors.
So by
Smear and bone marrow on microscope.
morphology.
Yes,
Next to
sir. Marrow
morphology,
morphology.
type special stains. Do you
Stains,
know
yes,
of
sir.
any stain
Myeloperoxidase staining is done.
which will be positive in?
AML.
Correct. So the next step is MPO staining or other PAS or Sudan black staining, and then
Yes, sir.
of course you have to we have to confirm nowadays by flow cytometry.
Flow cytometry.
So which CD markers will, do you know of any CD markers which will point diagnosis towards ALL?
CD 19 and 20 are positive in
Okay. Yeah, so
lymphoid leukemia.
correct. 20 is usually not positive in most of the
19.
cases. Yeah, 10, 19 and cytoplasmic 79A are specific for lymphoid, and for myeloid markers,
79 is positive.
for myeloid,
So, 3, 4, 5. Hello.
sorry, I'm getting calls now, that's why I'm getting disconnected.
So Suparna, I will just cover up for sir in between. Rather than going into the markers, can you tell us clinically will you be able to differentiate between a lymphoid leukemia and a myeloid leukemia? Are there certain clues?
Correct.
Gum hypertrophy is seen in myeloid leukemia.
Which type of myeloid leukemia?
Myelomonocytic M5 type of leukemia.
Correct. Okay. What else?
No, sir.
In ALL, which will point more towards ALL?
Ma'am, chloromas are there in AML.
Yeah, but how do you know chloromas? By just this thing, and that is on histology, you know it is chloroma.
Yes, yes.
Clinically, what will point towards ALL?
No, sir.
So you only said na, so generalized lymphadenopathy more common in ALL rather than AML.
Yes, sir.
Bone pains
AML. Yes, sir.
are common in ALL, not in AML. Okay.
Yes,
Testicular involvement common in AL. I mean, present in ALL only, unlikely in AML.
Yes, sir.
So these are all clinical pointers towards ALL.
Yes.
And suppose the patient comes with profuse bleeding and you have pancytopenia, which is the leukemia you are most likely to encounter?
Anything related to myeloid variety, subtype of myeloid?
No, sir.
No idea?
No, sir. No.
APML, acute promyelocytic.
Promyelocytic.
M3.
You see so many patients and then you don't remember.
Correct.
Yes, sir.
Correct.
Okay, Suparna, just going a little away from the leukemia series, which are the certain infections which you can diagnose by bone marrow aspiration? Infections which you can diagnose on bone marrow aspiration.
Correct.
All the three you are suspected.
And there's a fourth to it also, sir. And there's a fourth to it
fourth
also.
one also there.
Because see, sometimes they get bored in asking the same questions to 2 or 3 candidates. But तीसरे candidate को सब कुछ अलग ही पूछना शुरू कर देते हैं.
Yes, ma'am.
So tell me, infections कौन से फटाफट. सबसे commonest infection कौन से अपने infective bacterial? Can you diagnose enteric fever with bone marrow?
Yes.
Yes, ma'am. Culture.
Then what is the condition where you will send a bone marrow culture only?
No,
in
ma'am.
enteric fever?
No, ma'am, I don't know.
Okay. So when the
Yeah.
child has received partial antibiotics.
Partially treated.
Yeah. Second, one is entry fever. Second, what are LD bodies, beta? What are they?
LD bodies undergraduate मध्ये केलेस ना?
Yes, sir.
Leishman Donovan.
Leishmania
and Donovan.
Donovani bodies.
Leishmania
and Donovan in 1902.
So what are they seen in? Leishmaniasis म्हणजे काय?
काला आजार is leishmania.
Okay. Third, अगं असं काय करते? Which is the other infection which you can diagnose?
No, ma'am, I can't remember right now.
Okay, you can diagnose. Sir is saying ना तू तिन्ही already ठेवले होतेस ना तिथे?
Yes, sir. Brucella, malaria.
DDs आहेत त्याला ultimate test is bone marrow only.
Yes, sir.
Malaria पण diagnose करता येऊ शकतो.
Malaria and brucellosis
Yes,
you can diagnose ना. Ultimately, if you don't get anything anywhere, these are the only tests which you can do. सर तुमचा आवाज ब्रेक होतोय देशपांडे सर.
माझा नाही, मी बोलतच नाहीये.
कुठला तरी आवाज ब्रेक होतोय.
दुसरं कोणतरी बोलताय.
Sorry.
Any fungal infection you can diagnose on bone marrow.
त्याला गाईड लागतं ना, गाईड लागतं ना त्याला.
There's some cross connection.
नाही राजेश म्यूट कर. राजेश चालू आहे. राजेश म्यूट yourself. राजेश अनम्यूट झाला राजेश.
I think I'll give him a call in the meantime. How will you manage, Suparna? How will you manage this child?
Hello. Hello.
How will you manage this child? How will you manage this child?
Ma'am, once the diagnosis is confirmed, if it is
will you wait for the diagnosis for confirmation? How will you start management? Immediate management and otherwise?
Immediate management is to start with IV hydration and allopurinol supplement.
Why hydration, BP? You are probably thinking patient has
Fluid
edema,
overload.
fluid overload.
How will you initially stabilize this patient? What is ETAT? ETAT? What is ETAT, Suparna?
Triage.
And ETAT? Emergency triage and treatment. Right?
Yes.
So how will you do the ETAT in this child?
Ma'am, initially supportive management to maintain the airway, breathing and circulation if it is non-maintainable. Supplemental oxygen if the child is tachypneic or has respiratory distress.
Okay.
Fluids depending upon whether the child has significant fluid overload or not. Supportive IV fluids, anti-pain medications.
If the child is eating well, do you want to really start IV fluids if the child's oral intake has been good?
No, ma'am, but if it is like in this child, the diagnosis of leukemia was confirmed, so we started it because
that is confirmed. There will be time, no? I'm just saying this patient comes to your private hospital. You are not at Dina now. You do not have the facilities for any lab workup. How will you start treatment? You do not have a diagnosis in your hand. You just have a few lab reports like hemogram, etc. in your hand. You are in the periphery. How will you start treatment? See, when you are in a very big institute, it makes a lot of difference because you have things under you. When you are outside, that is what we are looking at. कि आप अगर peripheral health center में हो, आप क्या करोगे? या district hospital में हो तो क्या करोगे?
Ma'am, antipyretics, analgesics, prophylactic antibiotics.
And do you want to give blood products?
If the anemia is severe enough to cause signs of failure, then we'll transfuse.
Can you tell me the transfusion guidelines in a child who is sick? Tell me all the transfusion guidelines. In an ICU, what will you do? In the ward, what will you do? At what hemoglobin, what will you do? Have you heard there is a methodological RA by Suraj Gupte? No, it's got a very good. The recent one has good guidelines for platelet. Blood and blood products and transfusion. So please go through.
Yes, ma'am. Yes, ma'am.
The guidelines are there. All right.
Yes, ma'am.
Okay. So that's about blood. Do you start prophylactic antibiotics to everybody?
See, basically about this transfusion guidelines, most of the guidelines, general principle one should remember, it is when the patient is not requiring oxygen and that time and he is not in failure, then there is no need to transfuse. But he is in failure and is requiring oxygen, then whatever the physiological hemoglobin of that age should be provided to that patient. Should that physiological in neonate that may be 12 or 14, in an older child that may be around 9, 10. So if oxygen requirement more than FiO2 of 30%. This is the basis for all the guidelines. The figures may vary, they may complicate, but this is the underlying principle is the same.
Yes, sir.
And just to add to what sir saying, in any ICU setup, any hemoglobin of less than 8 would require transfusion. Less than 8.
7 cutoff ICU, sir. But again, they found that if you transfuse more than that, the mortality is more actually. Yeah, up to 7 the mortality. That was the paper for that basis for the NEGM paper.
NEGM paper.
Restrictive, as long as restrictive blood transfusion policy is there, it's always better. Of course,
7 is a cutoff for non-oxygen requiring patient in ICU. Oxygen requiring more than 30% FiO2, you provide the physiological hemoglobin of that age.
Yes.
Okay. So why do you say allopurinol?
Ma'am, to prevent tumor lysis syndrome.
So what are the diagnostic criteria for tumor lysis syndrome?
Hyperuricemia, hyperkalemia, hypophosphatemia. Sorry, hyperphosphatemia.
And?
Hello.
Hello, sir.
Is it hypo or hyperphosphatemia?
Hyperphosphatemia.
Necrotic
hypocalcemia.
Necrotic tissue contains phosphates. Remember,
yes, sir.
All the necrotic tissue contains phosphates. So there will be necrosis of the cells because of the anti-malignancy drugs.
Yes, sir.
So how will you treat it?
About treatment of tumor lysis syndrome. Yes. Ma'am, with hydration, allopurinol,
and
then we treat the electrolyte disturbances. And if it is causing acute renal injury, then we can go for hemodialysis.
Any other drug do you know that suppose despite allopurinol and your hydration, your uric acid is going up?
Rasburicase is given.
Correct. So what Raspberry case, how does it act?
Sir, uric acid excretion is increased in the
Okay.
renal excretion of.
Any specific precaution before using raspberry case ideally should be taken?
Sir, adequate hydration should be given because there were urate stones.
It can precipitate G6PD. G6PD hemolysis. Okay, related hemolysis.
Okay.
So ideally, all patients should be quickly screened for G6PD before using raspberry case.
Let's go in the basics. What
Yes,
is the G6PD and why it is required? Where it too much hi-fi.
Sir, glucose 6-phosphate dehydrogenase enzyme. It is a part of HMP shunt.
So
in the RBC. So if there is any oxidative stress,
what is the normal function of that? If it is present, why it is present? G6PD, what it produces?
Where does it act in the HMP shunt?
and acts on the glucose 6.
So what is the outcome of the HMP shunt? What it gives to you?
ATP.
It gives you NADPH2.
NADPH2. Sorry, NADPH.
And where the NADPH2 is required for the RBC?
For?
What is the glutathione?
Sorry,
glutathione is a tripeptide which is required for the RBC membrane integrity.
Stabilization.
Stabilization of membrane.
NADPH2 keeps it in the reduced state. If it remains in the reduced state, there will not the RBC membrane will be preserved. So if there is a lack of NADPH2, the RBC membrane will get disintegrated. That's why G6PD deficiency. So
Suparna, what type of inheritance is G6PD?
Ma'am, it is X-linked recessive.
Sir said, Sandeep sir just said that this child is this child, I will not even suspect it. I will do
X-linked recessive.
Correct. So
X-linked recessive type of
female
inheritance.
child, right?
No,
Yes,
but
ma'am.
G6PD deficiency is predominantly X-linked, but it has been described in various varieties. Various modes.
So, will you do in this child, in girl, this child? So ideally, yes, because why G6PD can still manifest even in girls if they are hemizygous?
Inactivation of the normal X chromosome.
Correct.
Lionization.
Lion hypothesis.
Lionization. And which is the community where G6PD is common in India?
No, ma'am.
It is in Parsis.
Parsi.
Very common, Parsis. Okay.
Very severely heterozygous, not heterozygous, but phenotypically variable disease, very severe in some African countries and all that. And it is not a single type of disease. It is
different mutations.
Sandeep would be more fit to talk about it.
So there are different class 1, 2, 3, 4 variants. Okay, so what we see is either class 2 or class 3, where we have mild to moderate deficiency. Class 1 mutations have severe deficiency, that means less than 10% G6PD activity, and they present with chronic non-spirocytic hemolytic anemia, which
they don't require any trigger also. They won't require trigger.
They are like pyruvate kinase deficiency. They'll require blood transfusion right from the infancy, many of them.
Yes.
So that is not usually seen in our country. What we see is class 2 or 3, where they have episodic hemolysis, which is precipitated by either viral infection or oxidizing agents like common drugs that we use.
Yes.
Which analgesic will you like to use here in this case, Suparna? You said I'll give analgesic, no, for the body ache pain. What is the analgesic you want to give?
Paracetamol I would give because the child has bleeding manifestations, so I would not prefer ibuprofen or mefenamic acid.
Okay.
So paracetamol in NSAIDs, and then we can use opioids if the pain is severe, which is not subsiding after NSAID.
Okay.
Shall we start?
Yes, sir. Yes,
Course
sir. देशपांडे सर तुम्हीच बोला ना.
नाही पण तूच वाइंड अप केलंस तर चालेल का?
नाही आहे ना, मला वाटतं सरिता आहे ना. सरिता can
सरिता.
Very well presented. Yes. Thank you so much, Sampada ma'am, Sandeep Bhadakke sir, for being available. Suparna, very nicely presented. No need to be nervous in the exam also. Yeah.
Yes, ma'am.
So straightforward cases, specifically like hepatosplenomegaly, vaginal, all the permutations, combinations.
Yes,
at least I think I would say ki make list of like what Sampada ma'am suggested. No, make list.
Yes, ma'am.
Splenohepatomegaly without lymphadenopathy, splenohepatomegaly with lymphadenopathy, this with pallor, without pallor, this all with jaundice. So usually these are very straight. I mean, they want 3-4 common lists from you. And the examiners are used to hearing those 4-5 differentials, which if you say, they will move on to the next thing. Okay?
Yes, ma'am.
Coming to subject specific, like what most of the questions I had asked, I will only summarize. From, I think at the PG level examination, you will be expecting most of the clinical questions in leukemia. Like I told you, can you clinically differentiate whether it is leukemia, myeloid, or lymphoid? Then some clues to T cell, some prognostic factors they might ask you, what are good prognostic, what are bad prognostic, and in general, the principles of treatment like induction, consolidation. Nobody might go into too much depth of that treatment. Yes, again, like general pediatric examiners like ma'am, they will be interested in the emergency part of management, especially tumor lysis syndrome. DND has repeatedly asked you tumor lysis syndrome. TLS is one of ICU, that electrolyte imbalances point of view also they will keep on asking. And your this xanthine oxidase inhibitors, raspbericase, they have always been put up as one of your theory questions as well. Okay? So I think ma'am and sir, Sandeep sir and Sampada ma'am, Deshpande sir, thank you everyone for being present. Very nicely presented. See you all after 2 weeks. Thank you, sir. Thank you, ma'am.
Thank you so much.
All the best
Thank you,
for
Sandeep.
your exams.
Thank you, sir.
Thank you.
Bye.
Okay.